So this is what the World Health Organization infographic says about diabetes. Over 400 million people have diabetes. That was actually in 2014. What's for me is the most striking, that's one person in about 11 in the world population. And what was most striking to me is how this has changed over time. In 2003, it was estimated that we would go up to about 350,000 by 2020. Well, we passed that in 2010, you know. This has gone up fourfold over the last 40 years. And this is not just because of a world population increase. The prevalence in 1980 was about 1 person in 20. So the prevalence is increasing and the incidence is increasing. So it's very serious. And it's a serious condition because it's associated with mortality and morbidity. So the types of diabetes, the World Health Organization, again, 3 different types. They all basically have an endpoint of high blood glucose, and that's how it's diagnosed. We're mostly going to talk about type 2 diabetes here. Gestational diabetes is temporary during pregnancy. And why is this important? Because of the consequences of diabetes leading to heart attacks, strokes, blindness, kidney failures. The leading cause of blindness, heart attack, 2 to 5-fold increase in risk for people with diabetes, leading cause of dialysis, and the leading cause of amputation of the lower limb. And we know that all of these complications are caused by high blood glucose, or at least that contributes to it, because we know that controlling blood glucose, reducing it, will reduce the incidence of these complications. So this is what guides the therapy of diabetes, to try and control blood glucose. Now, why does blood glucose go up in type 2 diabetes? Different kinds of diabetes have different reasons. In type 2 diabetes, here we have some glucose in the blood, and if the glucose level in the blood goes up, this causes insulin to be secreted, and insulin causes glucose to go back down by increasing uptake in tissues. This is a classic endocrinological feedback loop. And the ability of glucose to stimulate insulin is beta cell function. And the ability of insulin to lower glucose is insulin sensitivity. And insulin sensitivity and insulin secretion are related to each other in a population of people with normal glucose by this hyperbolic, or no, it was 1/x curve, like this. So that if you're very insulin sensitive, you secrete very little insulin, and if you're insulin resistant, you secrete a lot of insulin. And I don't have time to go into say, how does the pancreas know whether you're insulin resistant or not? That's a whole other story. But, insulin sensitivity is not something which is static. This changes from minute to minute through the day with lifestyle changes through one's life. And the ability of insulin secretion to be modified is a physiological kind of adaptation to changes in insulin sensitivity. So, for example, if you start here, and let's say you're going to do what Dr. Jung has suggested and do a little diet and exercise, you're going to become more insulin sensitive. And in order to prevent your blood glucose from dropping into your boots, your insulin secretion will go down. And if you gain some weight, or there are various other stimuli to increase insulin resistance, reduce sensitivity, your beta cell will compensate to secrete more insulin to keep your blood glucose normal. And that's what normally happens. The problem is if you become insulin resistant, and all of us tend to be doing that as we get older, we tend to put on weight, we become less active, our muscle mass goes down, and we're aging. We get insulin resistant with age. If you're unable to secrete more insulin, then your blood glucose goes up and you get diabetes. So for me, the critical thing for diabetes is not insulin resistance so much, it's the ability of the beta cell to compensate for that. And you can show studies where, following Pima Indians, for example, all of them are getting insulin resistant as they age. The people who get diabetes are the ones whose insulin secretion fails. The ones who don't, their insulin secretion increases. So in order to get diabetes, you need to have both a low beta cell function and low insulin sensitivity. And these things are independently genetically determined. The risk for diabetes is certainly very strongly inherited. But if you just have one of them, you won't necessarily get diabetes as long as the other one's present to compensate. And then this is a classic situation with a disorder of genetic susceptibility, which is exacerbated by the environment, which in this case is obesity, for example. So, what are the risk factors for type 2 diabetes? This is World Health Organization again: unhealthy diet, physical inactivity, being overweight or obese. And what are we supposed to do about it? According to the World Health Organization, eat healthy, be physical active, excessive weight gain. Okay, great. We actually know that these interventions work. The Finnish Diabetes Prevention Study, we've known about this for, getting on for 20 years now. This is an intensive intervention focused on weight loss and diet, and this resulted in a 58% less prevalence of diabetes in people who had impaired glucose tolerance, followed for about 6 years. And the great news is, the more you follow the advice, the lower the risk of diabetes. So even doing anything, one thing out of 5 reduces your risk. And this was supported by the much larger diabetes prevention program from the United States, where they compared the effect of metformin, a drug to treat diabetes, versus the same kind of lifestyle program. Metformin reduced diabetes by 31%. Lifestyle, the same exact number, 58%, significantly more than metformin. So great, we know diet and activity will reduce the risk for diabetes if you're at risk for diabetes. Okay, well, it's kind of moderately simple to know what to do to increase physical activity. You have to move more. And there's all sorts of ways you can do that. I guess my question is, what does it mean to eat healthily? We've got 30 million experts on diet in Canada. And my daughter, it was very interesting, she's 21 now. In high school, she was taught about Canada's food guide, and the one thing she remembered and used to judge how healthy a food was by how much fat it contained. And that reflects the focus of our dietary recommendations for the past 50 years or so to reduce fat intake. Well, after so much fat, advice for low fat, carbohydrates are becoming under attack because the food industry can make many very tasty low-fat foods which contain a lot of carbohydrates, and people overeat those just as much as they overeat the high-fat versions. And so we have all these books telling us that carbohydrate, starch, or sugars are bad, eating butter is good, eating meat is good, this is all good stuff. And we have all these different kinds of diets, low-carb diets. So, what about carbohydrates? What does the evidence show? What do we know about carbs? We really don't know very much, most people, because this is what we know about it from our food label. We've got carbohydrate, which is the sum of anything in the food which is not fat, protein, ash, or moisture. Most of it's carbohydrate. It's made up of sugars, and sugars are mono and disaccharides, glucose, fructose, high fructose corn syrup, which is simply a mixture of glucose and fructose. Disaccharides, the major ones, sucrose, this is table sugar, and lactose, milk sugar. And then we have, a lot of people make a big deal about, added versus naturally occurring sugars. And I was very glad to see this was not incorporated into the new food label. There's no test you can do. Added sugars are exactly the same chemically as naturally occurring sugars, and there's no chemical test you can do to tell how much added sugar is in a food. They're the same thing. Okay, so that's our sugars. And then we have starch, which is a bad word, so we don't talk about it on the label. And then we have fiber. So starch you can estimate by subtracting the fiber and the sugars from the carbohydrate. Estimate. Okay, so what I want to talk about today is carbohydrates and diabetes, risk for diabetes and treatment of diabetes. And we want to focus on the amount, which is really generally what people focus on, or the source. Where is it coming from? And I'm going to do two main things. I'm going to review observational studies, systematic review meta-analysis of prospective cohort studies. These are mostly what we use for getting our information for our dietary recommendations. But they're only observations. They show associations. They can't prove causality. So if you showed that, for example, high sugar intake was associated with increased risk for diabetes, that doesn't prove that eating more sugar causes diabetes. It's an association. Still, this is what we use. And I'm going to look at sugars and total carbohydrates. And then I'm going to look at randomized clinical trials for the treatment of diabetes, focusing on glycemic control, again, for sugars and total carbohydrate. So what about that for here? So what about total sugar intake and risk for diabetes? Association. And this might kind of surprise you, perhaps, given what our recommendations are. These are all the individual studies that were included in this meta-analysis. By the way, these are the most recent meta-analyses of high quality that I could find. And I'm co-author in some of them. These are the studies. What these observational studies do is they split a population up into tertiles or quintiles, quartiles. They compare the risk or the prevalence of or the incidence of diabetes in the highest intake versus the lowest intake, and that's the relative risk. So that's the number, and this is the graphic of it. Points on this side of the line mean that a high intake has lower risk than a lower intake, the lowest intake, and on this side shows that a high intake increases the risk. And this is the 95% confidence interval, and if it crosses 1, it's not significant. So what this shows is that, in fact, total sugars intake has not related to increased risk. If anything, it might be slightly reduced risk. The other thing to note is that this is I squared as a measure of heterogeneity. If it's more than 50, it's high heterogeneity. What that means is the different studies are not all telling us the same thing. The results differ. And this could be because maybe the sources of sugars differ, the populations might differ, the methods might differ. But overall, there's no evidence here that high sugar intake, total sugars, is related to increased risk. What about fructose? This is the one that has been likened to the toxic effects of fructose equal to those of alcohol or smoking. Well, certainly for diabetes, again, there's no evidence of increased risk. When we put it all together, there's heterogeneity. Some studies show increased risk, some show protection. And sucrose, table sugar, is actually significantly protective. High intake of table sugar is associated with reduced risk for diabetes. That's pretty surprising, isn't it? Yeah. And these studies are all saying the same thing. So I'm not here to tell you that you should go and eat sugar to prevent diabetes. But I think what we can say is there's certainly no evidence whatsoever that this high intakes of sugar are associated with increased risk. And why might it be associated with less risk? It's because there are foods containing sugar which might be quite good for you. We'll come to that next. Whoops. Sources of sugar intake. This is from John Sievenpiper, who's just won the Canadian Nutrition Society Award for, I think, Young Investigator or something this year. He's part of our group, I'm part of his group, really. This is each one of these points is a summary of a meta-analysis for different sources of sugar. And you can see that the risk for sources of sugars vary. The only signal for harm that's bad, increased risk, is for sugar-sweetened beverages. And for fruit juice, this one shows a slightly increased risk. Some more recent data suggests maybe that should just be neutral. And we get about 50 or 60% of our added sugars intake from these sources. But the rest, a large proportion, comes from other foods. And a number of these are actually associated with reduced risk for diabetes. So yogurt, ice cream, there's only 2 studies. I don't know about that one. Cereal, whole grain cereals, sweetened cereals, and fruit. So, and then the other ones in this area are certainly not harmful. So what this tells us is we're thinking about sugars and the risk for diabetes. The amount is irrelevant. What is important is where you are getting the sugars from, what foods you are eating. And the same goes for carbohydrate, total carbohydrate. This is the summary of the 3 big US cohorts. Total carbohydrate has absolutely no intake, has no association with diabetes risk. What is associated is whether the carbohydrates are of good quality. And the markers of carbohydrate quality include dietary fiber, whole grains, and glycemic index. Sorry, I have to talk about that here. And for those of you who are not familiar, and if you've heard about GI, you've probably heard something wrong about it. It's basically the glycemic impact of a 50 gram of available carb from a food expressed as a percentage of 50 gram glucose. It's telling you on a gram for gram basis how much the carbohydrate in that food raises blood glucose. It is not a quantity like on the food label. The glycemic index of one piece of bread is the same as the glycemic index of a loaf of bread. It's a qualitative indicator. So what is the evidence? Oh yeah, and this was our first study in 1981 where we showed all these foods, very large differences in glycemic impact. The reason for this was people with diabetes carbohydrate count, which assumes that all carbohydrates are the same, but they're not, they're very different. So fiber, increased fiber reduces risk for diabetes, high fiber intake associated with less risk. This is glycemic index. This is really quite remarkable. Okay, there's about difference of 2 GI units for each of these steps, and almost all of them are different from each other. Very strong. Glycemic load, this is a more popular concept. It's the grams of carbohydrate times the glycemic index divided by 100. This is slightly associated, but it's because most of the glycemic load is caused by the carbohydrate, which has no effect on risk. So this effect is due to the glycemic index. And whole grains, I couldn't find a study in the same sort of way, but this is a summary of a number of different studies. And you can see, again, the more whole grains you eat, the less associated risk for diabetes. So conclusions, sugars and carbohydrate, the amount you consume is not associated with any risk. This has nothing to do with the risk. It's the source of the sugars, harmful sugar-sweetened beverages, beneficial yogurt, cereals, fruit. And carbohydrate, no effect, it's the source. Carbohydrates high in fiber, whole grains or low glycemic index. These are the sources which are high quality, beneficial. Okay, so we've looked at, very quick, and I'm going to go quickly through the randomized controlled trials. Sugars. This is a very recent thing from John Stephen Piper's group. You see I'm buried in here. I'm a knowledge user, so right now I'm using the knowledge. That's my role on this study. Sources of fructose-containing sugars and glycemic control, okay, just published recently. This is very interesting. When you read the studies, these meta-analyses, the studies were included here which had at least 7 days duration, which isn't very long, really. And there are a number of study designs, and you have to be cognizant of that in the literature. Some of them are substitution studies. In this case, they're controlling for energy. You take away 100 calories from fat or carbohydrate or protein, and you add 100 calories from sugar. So it's calorie controlled, substitution. Then there's addition studies. I don't know why anyone would do those. You take a diet, and you compare that to the same diet plus 300 calories of sugar. I mean, anybody can tell you that's going to be bad. They don't have many of those in diabetes. In non-diabetic subjects, sometimes they control for that by adding 300 calories of fat or protein. And when you do that, both diets are bad, and the sugar's no worse than the other source of energy. Anyway, and then we have subtraction studies and ad libitum studies. We'll come to those in a sec. So the conclusion of this large meta-analysis is that energy control and the source of the food are the things that mediate the effect of sugars on glycemic control. So most food sources do not have a harmful effect if they're energy matched. Where there is a problem is when they're adding excess energy to the diet. And this is, I suppose, a problem of sugars because they do make foods taste good, and particularly in liquid form, they're easy to overconsume. But, food tastes good, and it's easy to overconsume, so depending on what kind of food you got. So quickly run through the data. These are the substitution studies. Substituting fruit for other sources of energy significantly improves glycemic control. Here we have sugar-sweetened beverages. They're to the left of the line on the beneficial effect side. Added sweeteners are beneficial, but not significant. Overall, we have a significant effect. If you substitute sugars for other forms of nutrients, energy-controlled, you tend to improve blood glucose. Why is that? Because the glycemic index of fructose-containing sugars is about 60 or 62. The glycemic index of refined starches is like 70 to 80, and if it's maltodextrin, it's 100. So it might be because they actually elicit a lower glycemic response. Addition studies, fruit juice adding drink to the diet is harmful when you add it to the diet. In fact, the other things tend to show no effect. There's only one subtraction study. This is where you take out fructose-containing sugars and replace it by water locality sweetener. There's no effect on control. And if you just ask people to reduce their sugar intake, a few studies, these actually tend to show a harmful effect because people can't control their energy intake. So another important conclusion is that the certainty of these estimates is low. And so in other words, this is what the current data show, but we acknowledge it's not very good. All right. Now, I'm an editor of this journal, and I was sent this paper to handle. I'm not a fan of low-carbohydrate diets. I thought I better not let that bias kind of affect my decision, so I said, okay, they can publish it. But we tried to ensure they edited it to make it the conclusions more kind of in line with the results. And they included studies where low-carbohydrate diets, as stated by the author, were used. A low-carbohydrate group must have achieved a lower carbohydrate intake, and a meta-analysis was formed. This was very strong for outcomes after a year. This is very important to have a long-term outcome data. And they indicated in the abstract the results that dietary adherence was a problem. Very low-carb diets that are not realistic for long-term use. But diets with about 130 grams a day, that's about 25 or 30% of energy, they seem to be achievable on a long-term basis. Improved outcomes were observed in some studies. And here are the data on glycemic control. Overall, small benefit. Some studies show benefits, others don't. And this is body weight. So some studies show weight loss. Overall, there was no weight loss after a year. So why do we have this difference differences in the results? I just kind of had a look at this. Is it related to the amounts of carbohydrate in the test diet? This is the change in hemoglobin A1C, the reduction. This is the carbohydrate content. Some of the low-carb diets had 40% energy. Some of them had 15%. But there's no correlation. You can't predict from the amount of carbohydrate or the difference in carbohydrate intake between test and control. The control of diabetes at the baseline wasn't related, baseline A1C, and neither was the body weight loss. So we really can't predict why there was this improvement. And we might think that, if you're on a low-carb diet, you have more fat in the diet, more saturated fat. This is LDL lowering, and again, none of these things were related. The carbohydrate content or the body weight change didn't relate to the cholesterol effect. So the overall conclusion is that, really, we need to understand how to classify a low-carbohydrate diet. Some of them might be beneficial, some of them may not, and certainly adherence is a problem. So I hope I've changed my mind to say that I'm quite happy to let my patients try these if they wish, and we'll monitor it for them. Some people do okay, some people don't. What about the quality of carbohydrate dietary fiber? Meta-analysis of the treatment of diabetes, just to be really quick, fiber showed a significant beneficial effect, and the most largest effects were seen with viscous forms of fiber like guar gum or psyllium added to the diet. Cereal, wheat fiber, and so on, not so much effect. Dietary, this is whole grains. There actually are no studies in diabetes of whole grains except this one from China, which almost seems unbelievable. They had 500 people, 298 at the end, large groups of people. They followed them for a year. They had a usual diet. You can see in China they had high carbohydrate diet. That was seen to be healthy, low fat. And then they had diets where they added oats. So these are your whole grains. Whole grains are not all the same. And at 1 month, the weight loss among the diets was not different from each other. The glycemic control improved on all of the 3 diets, healthy oats diets, at 1 month. Cholesterol was lowered most by the high oats intake, because that's thought we would think that's so because of the beta-glucan, soluble fiber. After a year, it looked like the diet high in oats actually had significantly more weight loss than the healthy diet, and better glycemic control, and a lower cholesterol. So maybe oats are pretty beneficial, but this doesn't say anything about other whole grains. And low GI diets in the treatment of diabetes, this was published a long time ago. This shows the difference in glycated protein. This means improved glycemic control. If you have the effect depends on your glucose. If you have diabetes, you're going to be beneficial. Even if you have impaired glucose tolerance, impaired fasting glucose, I mean you're going to be beneficial. If you have normal glucose, you're not going to get a glycemic benefit. There are other benefits, but not that one. This is a meta-analysis showing low GI diets and weight loss. 37 studies in healthy, overweight diabetes. There's only one here in heart disease. That's the one that looks bad. But this is a highly significant effect. So low GI diets help control body weight. And they lower cholesterol by a modest effect as well, which is kind of unexpected. So, conclusions about treatment of diabetes. Sugars, no harm if substituted for other macronutrients, but if they're consumed in excess, like sugar-sweetened beverages, they are harmful. Low carbohydrate diets may improve glycemic control. Results vary. And I think the issue is what's replacing the carbohydrate in the diet. Is it saturated fat, unsaturated? Mediterranean diet, lower in carbohydrate a little bit? That's really beneficial. But I'm not sure about eating lots of butter and steak. Carbohydrate quality, fiber may improve glycemic control, whole grains, depending on the source. Low GI has significant effects on glycemic control, weight management, and LDL, and it also predicts the effects of which fibers and which whole grains are going to have an effect. So what does Diabetes Canada have to say about nutrition therapy? I guess you'll have to see the lead author here is John Sievenpiper. These are the most current recommendations. And Dr. Jung told you how to do what you know you should do. I'm here to tell you I don't know what we should do. And in fact, this is reflected, and you probably like these conclusions, that in the recommendations. Now, there's a ton of these bullets. I pulled out, I thought, the most important ones. A variety of diets have been shown to be a benefit in diabetes. And people with diabetes should be encouraged to choose the dietary pattern that aligns with their values, preferences, and goals, allowing them to achieve the greatest adherence. A diet will not work if you don't eat it, right? And in terms of carbohydrate, they're saying what we say: select whole and less refined foods instead of processed foods. Pay attention to quality and quantity, and include low GI foods, legumes, whole grains, fruits, and vegetables, because these foods help control glucose and cholesterol levels. So I'll just end with the motto of the Australian GI Symbol Program, which is about low GI foods. These are relevant to everybody. They should be consumed every day, one serving at every meal. That's all you need to know about. You have to know the GI, of course. So thank you.